Hello, everyone. I'm very happy to introduce our next speaker, Professor Rajesh Sundaresan. So Rajesh received the BTech degree in Electronics and Communications from IIT Madras and the MA and PhD degrees in Electrical Engineering from Princeton University. He then worked at Qualcomm on the design and development of wireless modems. He joined IISc in 2005, where he is a professor in the Department of Electrical Communication Engineering, an associate faculty in the Robert Bosch Center for Cyber-Physical Systems, and the current dean of the Division of Electrical, Electronics, and Computer Sciences. He has held visiting positions at Qualcomm, the Coordinated Sciences Laboratory of the University of Illinois at Urbana-Champaign, the Toulouse Mathematical Institute, Strand Life Sciences, and the Indian Statistical Institute's Bengaluru Center. His research interests include decision theory, communication, computation, and control over networks, cyber social systems, and more recently, data-driven decision frameworks for public health responses. So we're very happy to have Rajesh. Over to you.
Okay, so let me begin. Yeah, thank you for the introduction. So I'll speak about data-driven decision frameworks for COVID-19 response. And it's, as the title indicates, it's going to be my personal journey as far as this COVID-19 response is concerned. This talk is going to be mostly about computational epidemiology tools and how an accidental epidemiologist and his collaborators got into building these tools. So let me rewind the clock back to March 2020. So it was the 10th of March 2020. We had a seminar that day at the Robert Bosch Center for Cyber-Physical Systems. At the end of the seminar, the colleague asked, wasn't the holding of the seminar unsafe? Aren't you worried about the coronavirus? So my immediate reaction was, what coronavirus? Of course, I had heard about the coronavirus because we had cases in Bangalore. There was an IT professional that had turned positive on the 24th of February. There was somebody from Dell on the 8th of March, somebody from Mindtree on the 10th of March, Google on the 12th of March. And then there was the first death in Karnataka. That first death was an indication of what was to come, that immediately perhaps triggered, either because of the death or possibly there was discussion to see if we must bring in some restrictions. It triggered the closure of all public spaces with high footfall in Karnataka. Malls, universities and colleges, etc. were all closed. And IISc was also one of those which was closed on the 13th of March, 2020. Now, that evening, I got a call from someone, a collaborator who was also in a senior leadership position. So that person said, the institute closed today. All the students are to go home over the next 2 to 3 days. There is some uncertainty about when to open. We have studied mean field models for control of packet delivery and opportunistic spread in delay tolerant networks. Is there someone who does such things for diseases in IISc? Is closure needed, for example? Can we use modeling to figure out when to reopen and things of that sort? Now, when this question was posed, I didn't know that there were people that were actually looking at many such things, particularly in the context of diseases at IISc, but none came to my mind at that time. And then we set to work because I had looked at some mean field models for control of packet delivery and opportunistic spread in delay tolerant networks. And it was a short jump from there to epidemic modeling. So I set to work, and the next morning it was clear why, for example, social distancing was proposed and whether closure was needed. And a day later, I wrote this particular report and shared it with my colleague. And you will see here things like coronavirus spread modeling, 15th of March 2020. And I also had this do not distribute. And there are contacts in this particular population. And these contacts are the ones that lead to perhaps infectious people spreading the infection to susceptible people. The infectious people themselves may, after some time, spontaneously recover. So one can model this. And when one models this, one can write down this Markovian dynamics, which tells what the increments in each of the number of people in these states, the susceptible state, or the infectious state, or the recovered state would be. And you can write it in terms of contact rates and the number of people in the susceptible state and in the infected state and so on. So the equations are not that important, but these can be written in this rather simple form is the one that I want to convey. Now, once you write down this dynamics, you can divide this by t and get the rate of change. Then divide this by n, and you get, instead of absolute numbers, you get fractions of the population in each of these states. And then you can pass to the limit, and what you get is an ODE system. So really, you're writing the generator for a Markov process here, and recognizing that this generator for the n particle system, as n goes to infinity, when you look at the empirical measures, the fractions in each of the states, it actually goes to something which is a first order operator, and that's why the limit is an ODE system. Now, this ODE system can be written in this particular way, and it even has a simple solution at the beginning of the pandemic. For example, at the beginning of the pandemic, the fraction that are susceptible is actually very close to 1. If you take Bangalore, for example, there are about 12.4 million people in Bangalore. And the number that are, when you start off, the infection is concentrated in small pockets, and therefore most are susceptible. And so you can take S of t is equal to 1, and you can get a closed form solution, which is here. So all these were nice, and we could get interesting solutions. And one could put down the conclusions here. One could take this to analyze the China data, the Wuhan data, and so on. But still, there were many parameters that we need to fit. What are the best fit parameters were things that were not clear, and I was pondering about them. Also, and already there were issues with respect to data. Hubei, the province where Wuhan is located, decided to report all its cases in one go as a sort of a corrective measure. And that led to a huge jump. How do you handle such things? Because when you're trying to do best fit parameters, you're trying to do it on the cases which have been reported. And then if you see a sudden jump, there are issues that are related to spreading this cases across time. And so one needed to handle all of those things. And I was thinking about that. But some things were immediately clear that perhaps you needn't have closed things down. It suffices to reduce contacts from an initial contact rate that could lead to an epidemic spread to something that is just lower than the recovery rate, so that the recovery rate will beat the rise of new cases. So once this is done, it kind of gave additional insights as to what actions one could take. And that's why the sort of reductions in activity, etc., help. We now know this quite clearly, but at that time, these were sort of new. And while we were pondering on this, I came across this epidemic calculator, which had, and another link to a Python notebook, which I'm sure many of you may have also seen, which did all of this, and in a much better and much more elegant and intuitive way, where you could enter parameters in this interface and get to see what was happening. And so it seemed like the activity that we had done was of some value, but it was something which wouldn't be of much use beyond that. It turned out that that such a simple model is something that is still in use in what is called the forecast hub, and I'll come to that towards the end of the talk. But as I was thinking about how to utilize those understandings and maybe get a better feel for how to modify the Hubei jump, there were other things that I learned. There were other events that happened. For example, I learned about the Diamond Princess cruiser and asymptomatics. So this asymptomatics is something that I had quite a bit of difficulty with, because I always kept reading it asymptotics, and it took some time for me to get adjusted to asymptomatics. And now I'm finding it difficult to go back to asymptotic. But anyway, asymptomatics, that's when we learned about that. Italy was struggling. We heard about cases in Lombardo, Veneto, and the struggles that they had in the hospitals there. France had announced closures, and my collaborator, who was supposed to come to India for a couple of weeks, he cancelled his trip to India. And then I learned about UK's, when other places were closing down, UK had the singular strategy of trying to achieve herd immunity at that time, which seemed rather brave to me. But it's not surprising. UK is typically different. If the rest of the world goes on the right-hand side of the road, they would drive on the left-hand side of the road, and things like that. But then they flipped the next day. And the reason for the flip was actually this report that came from Imperial College on the 16th of March, which was about an agent-based model. I'm going to speak about that at length in this talk. So the method sort of built a city, or in their case, it was actually the entire UK. It seemed very appealing. It was an agent-based model, and it was something for an entire country. Every individual had a digital twin, and home interaction was brought in, schools were brought in, workplace interactions were brought in, community interactions were brought in, non-pharmaceutical interventions could target each one of these places. And then you could sort of see what would be the impact of closure of each of these alone. And you could answer, for example, the question of when to reopen the Indian Institute of Science. So it seemed exactly like what the doctor had ordered. The projections, though, from this simulator were somewhat unbelievable. So we requested the lead author of the paper for the code so that we could test it out ourselves. But it turned out that he himself was down with COVID-19 at the time and didn't respond. In any case, even if he had responded with the code, which he later did, he opened up the code for everyone to see, scrutinize, and use. Even if he had shared it at that time, this was 18th of March 2020, we would have had to adapt the code for Bangalore, for example, because I was focused on what kind of unlock strategies might one want to employ for Bangalore. So why not, if we anyway have to adapt it, why not build it from scratch? And that's how this particular effort was born. So I gathered a few volunteers, mostly those who were working closely with me at this Center for Networked Intelligence. We were essentially looking at data analysis and how to maybe look at smart city applications. So that was the focus of the center. So I spoke to all of those and they all gladly agreed. And a few days, this is from the, so these were members of the Cisco IISc Center for Networked Intelligence. And then a few days later, I wrote to our Cisco contact. Could we repurpose these resources to work on COVID-19? And they gladly allowed it. And that's how our city scale agent-based simulator was born. So what does the simulator do? It actually creates a synthetic population of agents and it models the disease dynamics, subsequently models many interventions of the variety that I will speak about later, but it targets various interaction spaces. And then it simulates the spread of the epidemic in the synthetic population via a Markov chain. At the heart of it, it's actually quite simple, but it requires a gathering of a lot of data. So we built the simulator and applied it to two cities. One is Bangalore on the left side, and the other one is Mumbai. So both of them, if you look at Bangalore with its 198 wards, and Mumbai with its 24 wards, they are roughly the Brihan Mumbai Municipal Corporation area and Bangalore are roughly equal in size as far as population is concerned. I'm not looking at the greater Mumbai, but the Brihan Mumbai Municipal Corporation area. It's about 12.4 million people. But you can see from this picture that there is actually quite a bit of variability in the population. So for example, the color codes here highlight the number of people living in that. Darker the color, more the number of people. You can see that the areas are small, so the densities are quite varying. You can see similar sized areas in Mumbai are colored differently, and things with the same color, the areas are different. So the density is widely varying. And we know now COVID-19 is quite heterogeneous, and this kind of modeling might be important. And so it seemed like the right tool to use. So what does it take to build this agent-based model? You need lots of data related to the cities, population information, census data, a geographical information system. So if you're modeling, for example, the 198 wards, you need the ward boundaries in an appropriate form so that you can ingest it and then instantiate homes, etc., in that particular place. Then the data was not all that clean because they are in a certain format, whereas we had to standardize it so that we could feed it into our simulator to build the synthetic city. So there was quite a bit of curation that was involved. And the city building itself is an interesting exercise in sampling, where we have data about the populations, households, etc. You can think of it as some joint distribution that is specified through the marginal distributions. Only the marginals are available, so you have to sample the marginals and somehow build this joint distribution that respects all the marginals. So it was an interesting exercise in itself, and that was done using a supercomputer by itself. What does this involve? It involves several agents in the city, 12.4 million, several interaction spaces starting from homes, school, shops, markets, etc., factories, workplaces, hospitals, offices, and so on. And you associate individuals to each of these locations. An individual can be associated with multiple such locations, and there could be interaction across these networks. A little more abstractly, this is what you have. So I've here marked the black circles as the nodes, and then there are various interaction spaces. The interaction spaces there's one, for example, which is the household. So this is a 4-person household. This is another 4-person household. This is perhaps a 3-person household. And there are schools to which members of various households will come, and they are associated at the schools. There are workplaces to which members of various households will come, and they are associated at the workplaces. And then there are marketplaces, public transportation, community areas, etc. Now, abstracted, what is this? This is actually a bunch of bipartite graphs. There's the schools individual bipartite graphs, where the edge indicates an association of an individual with that particular school. There are also individuals and community areas bipartite graph, individuals, workplaces bipartite graph, individual homes bipartite graph. So it's really a bunch of bipartite graphs all connected through this single party, which is the individual that links all of these. And you start an infection, let us say, here is an individual that goes to school, picks up the infection there, comes back home. That person might transmit it to somebody at home. Well, this person may be asymptomatic, might travel to work. At work, the person may transmit to somebody. That person takes it to home and then perhaps may spread it to some others at home. So you can see that there is already an interaction between the various bipartite graphs, the school, home, workplace, community areas, markets, etc. So this is the social network, so to speak, of the city that we are constructing when we build the synthetic city. There are also various kinds of interactions. So for example, when you go to the workplace, you're not interacting with everybody at the workplace equally. There are possibly departments that you work in and you interact more with people there. There might be project groups, for example, or labs. And I'm thinking of a university environment. So people within that group may be interacting with each other. There are hostels, perhaps. Now, that says that there is a hierarchy of interaction, and agent-based models are such that we can actually build in this hierarchical interaction structure. Similarly, when you take schools and a school as an interaction space, children in one particular standard are going to interact with each other much more closely than with people in another standard. Of course, it doesn't mean that there is no interaction across standards. And there might be common areas that they might visit, toilets that might be common, canteens that might be common. But the interaction is stronger amongst classmates within a class than across classes. And one can build that structure in as well in agent-based models. So here is a picture of the real Bengaluru, at least as far as the marginals of the distribution of age is concerned. The blue one is the actual data. So this is age on the x-axis, age density on the y-axis. You can see the distribution is like this, and the red is our instantiation. There's a pretty good match here. Similarly, there's a pretty good match with respect to this time household sizes, workplace sizes, except that the number, this is in the log scale. So when you look at very large places, there is going to be quite a bit of randomness here. So the match there would be somewhat limited, but you see a good match between the data and the instantiation. Similarly, work commute distances, the blue is the data and the red one is our model. As you can see, we are trying to fit multiple marginals and yet respect we are trying to come up with a joint distribution by satisfying all the marginals, there are some constraints, and not all constraints would be satisfied because it will take quite a bit of time to make sure that every constraint is met. So here we sacrificed, for example, on the workplace distances and came up with a distribution which was a little bit off from the actual data. And this one is the school size. So you can see that the synthetic city and the real city matched to a great extent on many of the parameters.
Rajesh, sorry to interrupt you.
Yeah, please go ahead.
Maybe this is a very basic question. What do you mean by instantiation?
Okay, so you create, for example, 12.4 million agents, and those 12.4 million agents are put in households. Those households are placed in various wards, respecting the census data as to how many people are there. And you then have to associate people in these households in your simulator with workplaces so that the commute distances are matching with what we have here, and so on. So as you can see, you're sampling from the space of 12.4 million people and their various attributes, which lead to ages, household sizes, and so on for various associations. And an instantiation is one realization of this particular random city, which matches with the real city in all these parameters. I hope that clarifies the question.
Yes, thank you.
In order to complete the simulator, we need some other things, and I'm going to speak about the next important thing, which is the how the disease evolves in a particular individual. And this is something which is important because we know COVID-19 is actually a very heterogeneous disease. People that are elderly are more susceptible to it. People that have comorbidities are more susceptible to it. They probably suffer severe infection. There's a greater chance of being hospitalized. Now, when you build a homogeneous model, all of these variations are things which are difficult to bring into your simulator. Whereas if you're building an agent-based model, it can model if there are, let's say, X percent diabetic and this percent hypertension and certain other percent which are both diabetic and hypertensive, then you can bring those things into your model and instantiate individuals so that the population level statistics is respected. And then for each individual, you can have a progression that sort of matches our best knowledge of our current knowledge of how the disease evolves and impacts such individuals. So one can model this heterogeneity using agent-based models. So here is the infection progression across time in an individual. A person gets exposed, and then there is an incubation period where the virus is growing, and then your body is perhaps building a little bit of immunity, but the virus is catching up. And then there is some amount of leakage of the virus for people that might be pre-symptomatic or asymptomatic. And this is one of the features that we believe is spreading or something that spread the virus quite a bit without our knowing it, which is the asymptomatic information spread. But those could be pre-symptomatic in the sense that they develop symptoms a little later. So there is a random time for which this pre-symptomatic period exists, and then the individual might either recover, the body, the immune system of the individual wins and the person recovers, or possibly the person might start showing symptoms and there is greater amount of leakage of the virus. So about 40% from the Diamond Princess data were asymptomatic, and were truly asymptomatic, and that's what we believe might have been the case for the wild type SARS-CoV-2 virus. But this number is something which has been variously reported from 0.7 to 0.4. And so the symptomatic fraction also has varied from 30% to 60%. Then there is a period for which individuals that show symptoms will be symptomatic. And then depending on the individual's features, the person may recover or may get hospitalized. Hospitalized people may recover or they may be critical. And people that are in the ICU may recover or they might succumb to the disease. And all of these depend on the individual parameters. Elderly are more susceptible to go into this branch and so on. Similarly, people that have comorbidities. And so one would like data for this. This data, for a simulator, we use data from early studies, which were based on data from China, actually. And these studies were carried out by people in the UK from Imperial College, once again. And you can see from this data, these are all, there is interesting statistics that goes into this to come up with these estimates. 0 to 9, if they show symptoms, what's the chance that they would be hospitalized? 1 in 1,000. Between 10 and 19, 3 in 1,000. But those who are between 50 and 59, 10.2%. 70 to 79, 25%, and so on. And similarly, you can see that there is an age stratified branching probability for going from the hospitalized into the ICU, and similarly from the ICU to perhaps the diseased state. So these are data from China, and the analysis was done at the Imperial College. I wish we had gathered this data and done such studies. It requires an ecosystem where research coexists with clinical practice. Unfortunately, such an environment is limited in India. And actually, I would take this opportunity to indicate that IISc is embarking on on creating such a school, a PG medical school and a research hospital. And this is something that was announced just yesterday. There's going to be a hospital on the IISc campus, the Bakchi Parthasarathi Hospital, from about 2024. Additionally, you would need comorbidities data. What's the chance that somebody who's hypertensive with this ailment requires requires ICU, and then additionally invasive ventilation, etc. And then those that without the ailment that needed the ICU. So you can see that among those that needed the ICU, there was a greater portion that was actually hypertensive than those that weren't hypertensive. So this is the conditional on needing ICU. What's the chance that they were hypertensive? And these are the probabilities. Now, once you take all of these things, you can essentially look at each individual and what's the propensity for that individual to get infected at each time. So that's the lambda n of t. And this is actually the rate at which the individual will get infected in dt time. So lambda n of t times dt would be the probability up to order dt that this individual that is susceptible gets infected. And you can see that there are many factors, many interaction spaces through which the person can get infected. For example, the first one is a home. If you can see this, that's the home neighborhood. Then the next one is the larger neighborhood around the home, where maybe you're in an apartment complex and there could be infection from there. You count the number of individuals who are infected in that neighborhood. Each of them has a potential to transmit infection to you, and you capture that. Maybe there are friends and family that you visit across the city that might also lead to an infection spread. Infection could come from the school if the person is of school-going age. From within a class, that's also possible. If the person is of employable age and the person is going to work, then it could be from a workplace or within a workplace from within a project group, transportation space, market areas, and so on. So the point of this is one can build all of these infectivities or propensity to get the infection from each of these spaces, and then the overall propensity to get infected. And each dt time interval, you turn the state of an individual from the susceptible to the infected state based on this particular rate of the infection. So let me go to the next slide. Another thing that the agent-based model allows, and this is actually the power of the agent-based model, is it enables you to target certain interventions. So you have to model interventions, and you can see the effectiveness of this particular intervention. So for example, voluntary home quarantine could be something like this. Following identification of a symptomatic case in the household, all the household members are asked to stay at home. How good is this policy? Well, household contact rates may double during this period, and contacts within the community may reduce by 75%. Why 75%? Perhaps out of 4 people in a typical household, 3 of them stay at home, only 1 goes to the marketplace. And if at all there is a spread, it comes from this person. So that's a 75% reduction over a nominal contact rate. And then we assume not everybody is actually complying with this. All of these can be modeled in an agent-based simulator. I'm pointing this out to say that quite a bit of detail can go. And there are other details also that would be modeled. So seeing this, you might feel, and I felt certainly this way, that ABMs could solve, agent-based models could solve almost everything. Just seemed like the right tool to answer many policy questions. We could address, for example, Bengaluru's traffic. We could simulate and understand people's behavior and predict the effectiveness of, for example, the bus-only lane, which was attempted in Bengaluru. So these experiments, before actually conducting them live, you can actually do them in simulation, see whether they show promise, and then bring them into practice. Similarly, we could perhaps answer Delhi's perennial dilemma by quantifying the effectiveness of the odd-even strategy. Agent-based models can do this. So very quickly, we put together this simulator in JavaScript. You can still go to the cni.isc.ac.in/simulator, and you can choose your city. There are about 4 or 5 cities that we have, and only up to 1 lakh, because running this involves some cloud computing. So we have restricted the size to 1 lakh, and you can say how many days you want to simulate. You can set in some parameters. You can even create your own lockdown scenarios, your own intervention scenarios. Please go take a look at it, and you can let the simulation run, and you can see that the cases, the recoveries, etc., happen this way. Also, the source of infection, etc., from home, from school, from workplace. What are the chances at each of these places of getting the infection? All of these can be seen. So we built the simulator more as an educational tool while we were actually building the larger scale simulator. But building this synthetic city and simulator wasn't easy. We sought volunteers. It was a crowdsourced effort. We spoke to hundreds of people about ABMs. We tried to get Mumbai people to model Mumbai, Delhi people to model Delhi, Kolkata, Palakkad. We convinced some of the best CS theory and applied probability people to join forces. We got some volunteers from this company, SAP. We also, there were many students who were eager to contribute. There was energy that they displayed. They were just waiting for some channelization, waiting for a direction. And we all joined forces. From TIFR, for example, Sandeep Juneja, Piyush Srivastava, Ram Prasad Saptarishi, Prahlad Harsha, and their students all came forth to build this simulator. And I'm so glad they joined, because we turned our JavaScript into C++. We parallelized it, made it efficient, made it robust to concurrency issues, which the original simulator that Neil Ferguson and his team, the Imperial College model, had. I think from the start, we took care of all of these concurrency issues. And then we scaled up to 12.4 million agents and 2 big cities, Mumbai and Bangalore. And then as we were building this, a lot of things were happening. For example, the national lockdown came on the eve of 24th of March, 2020. It was our attempt at a zero COVID strategy. And it felt like we were entering a Chakravyuh. In many respects, it was entering a Chakravyuh. But on 13th April onwards, there were some guidelines for unlock. Actually, when we were entering this, we felt that our model, agent-based model, would be something that would help discover the right unlock strategies. And some guidelines for unlock came about from the 13th of April onwards. But things were going far too quickly for our simulator to catch up. And we were also at that time doing some counterfactual simulations. What if this happened? What if that happened? The kind of things that academics would be concerned about. Whereas a colleague said that, look, at this point of time, you have to model reality so that decision makers may actually find it useful. So this colleague knocked some sense into us. And then it took us a couple of days to reorient ourselves. And then on the 19th of April 2020, we put out this report. This report is something for Mumbai, where we got the fatalities. It involved this synthetic city for Mumbai, calibration of the deaths. On this axis, you see fatalities. On this axis, you see date. We calibrated the simulator. You can see shaded regions here, the soft lockdown from the 13th of March or thereabouts. Mumbai had already brought in some restrictions, the national lockdown, and then the unlock that happened from 21st or so onwards in Mumbai. So we calibrated up to about 8th of, so this is April 1st, up to about 8th of April. There were about 200 deaths in India up to about that time. And then we built in these lockdown models, etc. But the calibration happened only up to this time. And then we let the simulator run. We had several no restriction scenarios, and then lockdown scenarios, and then lifting of the lockdown. And we could see that if you look at the deaths curve, that was actually tapering because of the lockdown. And our simulator also turned along with it, which was not modeled, which was not put in. We just brought in the parameters for lockdown. And it was reassuring to see that, yes, perhaps this is actually something that we could use to understand how to unlock and things like that. So we felt that the model predicted at that time that there might be about 25,000 deaths. As of the 4th of January, when I pulled this particular slide from the paper, and I looked at the data, there were about 16,384 reported confirmed COVID-19 deaths in Mumbai. So not too far off, except that the deaths were also because of not the wild type alone. There was the Delta that came and created havoc as well. This is from Bangalore. Bangalore, we had a different problem because Bangalore closed down a little early, unlike Mumbai, and therefore the data that we had was somewhat noisy. So we were struggling to match it, but this is what we are. I'll show you a subsequent plot where we will see this up to about 100 or so. But this is what we had for Bangalore. For Bangalore, the number of deaths was similar, about about 20,000 or so. And as of 4th January, the actual number was about 16,411. So what this, when we put out this report, it actually created an uncomfortable situation for many of the authors of this particular report. We were in a situation where we were doing a press release before an archive, let alone a peer-reviewed publication. We had never done such things. And we were very uncomfortable doing this. We still are uncomfortable about this. But we had to do that because that's what got us the connect with the policy makers. And the next day, somebody from the Karnataka State Disaster Management Authority called us in for a discussion. The person listened to our model politely and posed several questions to us, all very insightful questions, because that person had a model himself, and he was comparing and testing our model against his as well. But what he then, after the discussion, there was quite a bit of back and forth about what ought to be the purpose of the models and so on. At the end of the discussion, there was a nebulous question that came up. And the nebulous question, which I have now articulated with a little more clarity in hindsight, is the following. And that led to our first city scale simulation study, which is what if, so there was the unlock strategy that had come up. We open up 3 workplaces, the IT and IT enabled services, government offices, manufacturing units, and the special economic zones which had access control. If we open those 3 things up, should we open them up at 100% and 50% and seek greater compliance when we open up? Or shall we maintain status quo because we can't get this greater compliance? There is poorer compliance. What but we still remain closed. What would be the outcome? So is this poorer compliance something that's going to be worse than opening it up with greater compliance? What such a study would say, if this is better, if this is worse and this is better, for example, then it says that you must invest a lot more resources into educating people to be more compliant and so on. So here is the outcome of our study. And the big takeaway was indeed that if you keep, if you have greater compliance, so you should focus on this, where we open up the workplaces with 90% compliance versus you keep everything closed down. That's the lockdown curve with 70% compliance. Actually, the continued lockdown with 70% compliance was going to be worse than opening up, but ensuring that people comply. Okay, so this is actually possibly a no-brainer, but you actually see a quantification here. And that's what reassures us that we should go and invest more resources in an education campaign and so on. So the big takeaway was allowing these 3 workplaces does not lead to much variation in the estimated cases, but compliance. So if you look at these 2, whether it's 50% or 100%, there isn't much difference. But compliance or no compliance or greater compliance matters. And the Bangalore trend, here is the one that I was alluding to, about 100 deaths. This was around the 3rd week of April. We had about 100 deaths at that time in Bangalore. And the Bangalore trend was captured by the 70 to 90% compliance model. So this was one of the studies, kind of reassures us that we must invest more in compliance. While we were doing this in Bangalore, our Mumbai colleagues, the TIFR colleagues, were actually working with the Brihan Mumbai Municipal Corporation people, and they were looking at phased unlock and start of trains in Mumbai. So, for example, they were looking at effectiveness of containment zones. What if trains were opened 30% in September, 60% in October, 100% in November? And remember, these were times when we were thinking that perhaps we can get away with just whatever we had seen in July, August, or thereabouts. And when we open, perhaps we can open the offices in a staggered way. What if trains, this was one big concern. Of course, in Mumbai, that's always a big concern. If the trains interaction, we have some limitation, but if we open it up a little bit more and have 50% more people than the base level. Base level is a base restricted level, 50% more than that. What would be the consequence of that? So here are some simulation curves. I'll not dwell on these, but you can see that there is a good match between the projected curves. The actual deaths are in red, and there are various scenarios. All of those are highlighted here. And there, in Mumbai too, there was some reporting delays, etc., which are highlighted by these irregularities here, and the jump that you see here in the simulated number of in the fatalities. The simulated number of fatalities is, of course, smooth. So this is just to highlight that our colleagues were working with Mumbai, and that the agent-based model can give rise to good matches. We were doing some other simulation studies. For example, we were already interacting with the University of Virginia, the Biocomplexity Institute collaborators there were working with us on some of these agent-based simulators. When Google came and said that Google has been putting out these mobility reports, so they came and asked us, okay, perhaps we can collaborate and see how to put that mobility data to good use. And maybe we can think of scenarios like these, where we can look at, we know already that your city-scale agent-based network has social network structures. But when we open up the Mumbai metro, why don't we structure the interaction even more? What is that structuring? That structuring is something that's enabled by cohorting. And there's something that already happens in Mumbai. People, every morning they take the same train. There are several that take the same train. They even get on the same coach and they become lifelong friends. So why not make use of this and have cohorting as a means by which we could structure the network interactions? And this cohorting has three benefits. For example, the additional structure can limit the spread of the infection. It can also help target testing. So for example, when you know that somebody is positive, it's likely that others in that cohort are positive. It also enables targeted isolation. So even if they don't test positive, you can say, okay, stay back at home because it takes 5 days for you to start showing the symptoms and test positive, so be at home. So targeted isolation. So for all of these reasons, cohorting seemed like a fantastic idea. And we built this cohorting framework into our agent-based simulator. And we found the following very interesting thing. So for example, structuring cohorts alone is not enough. It does structure the interactions, but still the infection spreads eventually. Somehow cohorting with isolation of the cohort when you find somebody that's positive is very important. So just the first item alone is not enough, but the targeted testing is also, targeted isolation is also important. And there were many other such insights. For lack of time, I will not dwell on them. I'll give just one example. Detecting symptomatic cases at the stations was crucial. Of course, at that time, we believed that temperature check devices actually worked, and we were hoping that they could be put to good use, and so on. Additional, maybe we can give even fixed seating, like in long distance trains, and additionally structure inter-cohort interaction. But this didn't help much. And so we developed many insights like this. It's very sensitive to crowding. Larger cohort sizes are better. And the number of people that are quarantined would not be too large as a consequence of this. Although the reasons for which you're cohorting, you're isolating them, sorry, the number of people that are quarantined is not too large. Although the reasons for the quarantine may not be convincing. You're quarantining because somebody in the cohort that they had been a part of tested positive. And so that's less compelling a reason for somebody to stay home than if one of a friend or a relative is positive. So people may not comply as much, but nevertheless, the number that are quarantined is not too much. Also, cohorting is beneficial even if there are some one-off travelers. You can bring down the infection rate with even if only about 60% of the people cohort. So we had a report on this. and shared it with people. Niti Aayog felt that this cohorting idea was too bold an idea to ignore. Therefore, they set up a meeting with railways personnel and called in many people, metro officials of few cities, an AIMS doctor, and other stakeholders. And when we presented it at the end of the meeting, all of them highlighted all the implementation related difficulties that would come when we actually take this to the field, and the tracking, logistics, etc. Ultimately, it was decided that perhaps we'll not experiment with this, but the feedback that we got was maybe we look forward to seeing a simpler version 2. And indeed, in version 2, we thought of some simpler strategies where cohorting helps, but maybe there is just a simple gating strategy. For example, I'll just go to this particular gating randomly. So if you see that there are this many number of cases, you just don't, you reduce the number of people that use the trains on that day, the locals on that day. A sort of signal that asks people to stay back, the color codes, that seemed to work. And you should employ that color code in the locals itself. At the train stations, you should gate people from coming in. So this is something that could be done. But I think by the time we had the study, the first wave was waning, and subsequently there was perhaps it just turned out to be a paper, but we couldn't take it to the field. I'll now highlight some skepticism that we faced when we were building this. And this is a skepticism that came all too often. But Professor Rajesh, aren't there are too many parameters? Won't we be overfitting? In defense of agent-based models, these agent-based models are actually constructed bottom-up. We get the city constructed from census data, from the household size distribution, the household mix, commute distances, etc. The disease parameters are based on clinical studies. They are not changed or tuned to match to the data. Past flu cohort studies suggest relationships between school and office contact rates, for example. And then the only things that we are tuning are contact rates, a few parameters, about 4 or 5 parameters. When does the infection come? And what kind of compliance and testing is happening in the city? So these are the only things that are being calibrated. And the calibration is also done on an independently generated smaller system, and then we take it to the larger system. So there are quite a few checks and balances that have been put in place. But when we saw how the testing numbers were fluctuating, how case ascertainment depended way too much on people's willingness to get tested and the number of tests that were done. And we have seen this in the Omicron. There has been quite a bit of untested individuals who had symptoms. We realized what we were up against at that time. So this was a simulation of a 1-week lockdown in Bangalore to simulate, the lockdown was actually to prepare for the upcoming surge. And we could see somewhat downturn and upturn, but we had to do quite a bit of matching to even get to this level. And if we change the parameters, for example, this curve would be way up or way down. So it was too sensitive. And at this point of time, we said that, okay, it requires a little more work, an understanding of how testing is being done, what are the reporting delays and so on. We couldn't simply handle all the complexity. So one could ask, what good are agent-based models for? Well, agent-based models they're difficult to match the myriad variations. And when you take the outcome to the stakeholders, they actually expect for some reason an exact match in order to adopt the tools. Otherwise, there is always a sense of skepticism. There was also this call for a supermodel, and one of the supermodel committee members indicated, can your model scale up to hundreds of cities and districts? And of course, we were nowhere near that. Could your model be created? Can we create an instance on demand? It required lots of data and careful tailoring. We were nowhere near that. Subsequently, we did create Wuhan, New York City, Cochin, Mysore, Delhi, Sweden, but it really wasn't ready for scale up, and there was too much hand tuning that was going on that we had to abandon this particular plan. So what are ABMs good for? I think ABMs, agent-based models, are still good for scenario A versus scenario B comparison. They help you identify the right instruments to use and target them for interventions. They also are useful in smaller scale settings. For example, campuses. You could bring agent-based models for campuses. And in fact, we have turned our attention to campuses We have now models for 3 campuses, IIT Jodhpur, IIT Hyderabad, and the Indian Institute of Science. And this is actually a part of what is the Campus Rakshak as a service offering, which has things like the Go Corona Go app, the Tapestry pooling testing protocol, health badge, and then it has 2 other agent-based models. So you can go to this website, campus.readiness.in, create an account, and you can create your own campus. There are some example campuses that you can download and work with, or you can reach out to us and we will be happy to build a model for IIT Gandhinagar, for example. So this is what we have been using the agent-based simulator for. So I'm already at around 48 minutes. So let me maybe skip this. At the end of this, we connected with the Karnataka State Disaster Management Authority, and they asked, okay, can you, instead of this agent-based simulator, can you build some tool which can help industries assess how ready they are? So we actually built something with an epidemiological tool. We built this readiness calculator, which sort of took various actions that the individuals the organizations could take. For example, there are 10 sets of questions on the infrastructure of the campus, the employees, the precautions that were taken, the actions that were taken, and so on. And you could also indicate the nature of the organization, whether it's a software park or PPO or manufacturing entity, a bank, government office, R&D institution, and so on. And here are the various features on which questions were asked. And then once you enter all of this, you would get a score. This is a score for the Electrical Communication Engineering Department at the Indian Institute of Science. And the score says that it's doing very well in a few parameters, a score of 100, 95, 92. But there are some where we could improve. And there are some employee interactions and meetings where we definitely had to improve. The score was too low. And we even had some personalized suggestions for that. So we took this particular, when we were working on this tool, I was discussing with a colleague, Shiva Atreya from the Indian Statistical Institute. And as we were doing this, he was in touch with the Karnataka Department of Health and Family Welfare Services. He was closely following the daily bulletins and he was building contact graphs on the bulletins. He had several issues to report and he suggested many fixes to the Department of Health and Family Welfare Services. He built a tool, for example, to catch errors, like someone who was declared deceased on day N was subsequently declared as recovered and discharged on day N+5. And the Karnataka, so he would issue alerts like these, and then they would be rectified on a subsequent day. So he gave quite a bit of input of this sort. And then we got to talk to them, and they said we have actually a slightly different problem. And the different problem was something that led us to build another tool. And this tool is called the Swaps to Labs a tool, where we said how the state could use the existing lab capacity. Remember, these were early days and the lab infrastructure was just being built at the time, expanded at that time. So how the state could use the limited lab capacity to the fullest extent. So I'll not go into the details of this because of lack of time. I'll switch to some other things, but I'll just highlight some issues that we had. For example, when we conducted a serosurvey, we could actually track some of the samples. And these were the samples from the time the samples were collected to the time the data entry was made in the ICMR webpage. How long did it take? So you can see here that there were many that were done within a day, some after 2 days, the mode is 3 days, but about 1/3 of the samples took 4 days or more. And this was actually a significant factor because in the second wave, during the Delta wave, we were actually, you needed this BU number. It had to go to the ICMR webpage, it had to be downloaded onto the War Room portal, and then the War Room portal, somebody would contact you. But if it took four or more days, it's too late by the time this particular information comes. And a BU number, for example, was, I know of one particular individual who was given this BU number 4 days and 21 hours after the data was actually, the report was given to this particular individual. So I think such delays we could have avoided. This was an acute problem noticed at that time. They asked us if we could help with this. Surely we could do better. And we came up with a tool to essentially allocate swabs to labs. It was a simple multi-round linear programming operations research problem. I'll not dwell into the, you allocate locally and then within 3 hours and then across Karnataka and use your testing resources more efficiently. And these are the kinds of transfers that would happen. We built this tool, tested it, integrated it into the War Room portal as well. But the switch was not turned on because by the time it was time to turn on the switch, we were in the second part of October. They were actually trying to manage the cases to the extent they could, and people had to be retrained, and this retraining would have cost a certain amount of time. For that reason, we weren't ready to switch this on, even though it was tested and integrated. But this is the kind of benefit that we could have had. These are the backlogs that we saw from the 1st October to 22nd October in the data that the state shared with us. And had we employed the particular tool, there were 4 different algorithms that we had. These are the kinds of improvements that we could have made. The backlogs would have been much smaller. So this could have helped us quite a bit in wave 2, but the circumstances were such that we couldn't integrate it into the platform. But we did use it as a means by which we could engage college students and get them to come up with perhaps be engaged with it, increase awareness. So whatever solution we had built, we took the questions that we had tried to answer, abstracted them, simplified them to some extent, and turned it into a hackathon and had several teams participate. And the outcome was that we had IIT Hyderabad, IIT Guwahati, and IIC Bangalore, as well as people from BMS College of Engineering in Bangalore, as well as VIT in Pune. All of them contribute to solutions to these. It was a competition for college students just to get them engaged. We've also been involved quite a bit in Karnataka COVID-19 serosurveys. Maybe I will just quickly skim through this. It involved gathering samples from about 290 centers. All 30 districts were covered, 31 now, plus Bengaluru was split into 9 units. We leveraged the state's AIDS prevention and TB surveillance teams to conduct the survey. When we came in, there was a sort of ad hoc design, but here is where there was quite a bit of missing data as well that needed to be handled. And here is where some mathematics came in, where we came up with a formulation of an optimal design that took into consideration test costs and test reliabilities and identified what ought to be the right test design. And in the second serosurvey, which was conducted about a year back, we implemented this much simpler serosurvey. And these are the kinds of outcomes that we saw. So you can see the kind of spread that is there across the districts. So in the interest of time, it's about 55 minutes now, and perhaps run all the way to the, I have several other things to say, but perhaps maybe for another time. I will just come to some concluding slides by highlighting a few points that I want to make. First, we have continued this COVID-19india.org effort in the incovid19.org website. So as of January 1st, we had already had about 500,000 page views, about 58,000 users were engaged. I think during the Omicron wave, we are likely to have seen a lot more engagement. So I urge all of you to go and follow this particular site to see how the pandemic is evolving. You can also see some models and outcomes there. And we looked at, recently we did some Omicron projections as well. And here is how the India projections were made. That's the red. The red is the actual, the blue is the is how we felt if India followed the South African trend, the projections would go. And it appears that because perhaps of the hesitancy in testing, we are actually following the South African trend. whereas reality may be a little higher. There are two other scenarios that we had given at that time. We also did a recent study of the impact of curfew, to what extent it could be effective. And as a consequence of our Omicron study and the subsequent curfew effectiveness study, Karnataka actually stopped the weekend curfew, thanks to some of our efforts. And subsequently, the following week, even the night, they continued with the symbolic night curfew, and then the subsequent week, even the night curfew was lifted. So here are some concluding remarks. I've given glimpses of many tools we built for data-driven decision frameworks, and we hope we'll be able to make these more mature to respond to future pandemics. But I think there is an impending mental pandemic that we should be aware of, and we should prepare for that. So should we have kept our schools closed this long? Should we have kept it open with better preparations? And perhaps that might have been better. Primary school should perhaps be open, and this was the case in Europe and in other places, but we did exactly the opposite. We actually closed our primary schools, and even when we opened for the higher classes. This might have an impact on literacy levels. People that would have otherwise come to school and been lifted out of illiteracy, now perhaps they're going to continue for another generation or so. So the impact of these are quite severe. It has been a struggle to get data. When all districts' data is centrally available, for example, at the ICMR portal, the COVID-19 India.org people were doing a fantastic service, but why did they even need to come together? The ICMR portal could have been leveraged to provide this data for everyone. The PSA's office, actually, the principal scientific advisor to the government of India, his office indicated the data will be available. We could have done many interesting studies with it, but somehow I think this we engaged with ICMR and NCDC, but we haven't been able to get them to release the data to us. There's been a struggle to even share the serosurvey data that we have. We haven't been able to convince the stakeholders that the serosurvey line list data can be shared to other researchers, and they might be able to find better methods of analyzing it. We have already anonymized it, but this is the difficulty that we are having. And I think just like there is judicial independence, election commission's independence, accounting independence, I think we must work towards data independence as well. Another aspect is science communication. I said very uncomfortable with this press release first, so social media next, medRxiv subsequently, peer review last. And the science communication by Twitter is something that makes me a little uncomfortable. Either we have to get used to it, or maybe reach a new equilibrium, or perhaps change the way we communicate these things with the public. We have had a rich set of insights and district-wise recommendations and actions, but response to it from the districts has been slow. And I think this is something that we can work on and improve, and we should do that. We had several optimal designs. We should leverage it at the national scale. The idea of sentinel sites that we used in our serosurvey, 290 sites, for example, something like that can be replicated in other states as well. And we should also conduct more frequent serosurveys if at all future pandemic comes. And this gives a template. We should standardize all of these things and the test kits as well. The stored sera, for example, is something that clinical study, this is related to clinical study. The stored sera that we have is very useful in understanding our immunity against new variants. For example, against the Omicron, we could have done it in November itself and been ready with it. And also the kind of impact it would have had on the hospital structure would have been better estimated if we had done some clinical studies. But somehow we have not been able to convince researchers to do this in the lab, while elsewhere such studies were done. So it appears to me that there is a separation between service-oriented research and basic research. And I think that's something that barrier is something we should break. Chetan, over to you.
Oh, thanks a lot, Rajesh. Unfortunately, we lost you for a few seconds there.
Sorry, yeah.
Yeah, not a problem. Thanks a lot. That was a fascinating talk. I just want to ask the audience members if they have any questions.